Hi, welcome to today's seminar on dyspraxia or developmental coordination disorder, which we'll refer to as DCD. I'm Helen Grimes and I'll be delivering this seminar today. If you've got any questions, please do get in touch. The objectives for this session then are to gain a deeper understanding of the characteristics of DCD dyspraxia across the developmental age range, to examine some theories behind its etiology, and to introduce possible support strategies, which will then be explored a little bit further next week. Firstly, we need to understand if we're talking about developmental coordination disorder or dyspraxia, or perhaps both. Now, we are talking about a condition that is a specific difficulty which affects physical coordination, and it was formerly known as clumsy child syndrome or physical awkwardness. And the term dyspraxia was first used in 1984. It's derived from the ancient Greek dys, meaning ill, or wrong, and praxis, which means doing. Both the NHS Dyspraxia Foundation and many other organisations and professionals use the terms dyspraxia and DCD interchangeably. But we now come to think of developmental coordination disorder, DCD, as being the more commonly used term, and this is because this is the diagnosable condition according to the DSM-V, as opposed to a more descriptive label. However, the length of time we've been using the term dyspraxia means that we do still use it as that descriptive, easy to recognise label, in the same way really that we would find it difficult to start calling dyslexia something different. A lot of people have heard of dyspraxia, they may not understand that we now call it DCD, developmental coordination disorder. So the definition which is most often quoted is from the Diagnostic and Statistical Manual version 5, which is from the American Psychiatric Association, and this refers to DCD, developmental coordination disorder, and not dyspraxia, which is why there's been this shift to this label being used much more commonly, because this is what the professionals will be using to make that actual confirmed diagnosis. So to understand what DCD actually is in terms of that diagnostic criteria, we need to look at the DSM-5 classification, where it's classified as a discrete motor disorder under the broader heading of neurodevelopmental disorders. And here are the criteria as follows. Firstly, acquisition and execution of coordinated motor skills are below what would be expected at a given chronological age, and also opportunity for learning that skill. Difficulties may be manifested as clumsiness, for example dropping or bumping into objects, and a slowness and inaccuracy of performance of motor skills, for example catching, throwing, using scissors, handwriting, riding a bike, or participating in sports. So that gives you a picture of the sorts of behaviours we might see in an individual with DCD. Another important factor in diagnosis is that the motor skills deficit would be significantly or persistently interfering with the activities of daily living in that individual, according to the chronological age, for example, self-care, self-maintenance tasks, and also in impacting then on the academic and school productivity, and also any other activities, including leisure and play. Imagining then thinking about maybe a child who isn't able to ride a bike at an age appropriate time, maybe a child who isn't able to join in with team sports, maybe a child who isn't able to take care of themselves in terms of hygiene and cleanliness. Another factor is the onset of symptoms being in that early developmental period. This is something that's with that child from day one, from very early on, and we start to see some of these symptoms appearing as the child develops and grows. And then also the motor skills deficits would not be better explained by an intellectual disability or a visual impairment, and they wouldn't be attributable to a neurological condition affecting movement, for example cerebral palsy, muscular dystrophy, or a degenerative disorder. As with other developmental disorders, there is a great deal of debate and sometimes controversy. Hill and Barnett's article gives a really comprehensive overview of DCD, including the evolution of its definition and also the role of psychology in better understanding the processes behind the difficulties observed. So I do recommend that is a recommended article to be reading. It's referenced at the end of this lecture, and I've also put it in the further reading section for you on Moodle. So let's look a little bit more closely at the main areas that would be impacted potentially by DCD. We're going to think now about the gross motor skills. So they're those big motor movements, so running, jumping, cycling, kicking a ball, all of those big motor movements, catching, throwing, those sorts of things. So first of all, I want you to imagine you're about to kick a football to another person. And think about what's actually involved in that. What would you have to go through to do this process of kicking a ball? Think about what you have to think about, what you need to process, what you need to be able to actually do physically, what you need to be able to perceive. And just take a couple of minutes before you move on to the next slide to think about all of those different areas, what's actually involved. It's the mental imaging, planning and execution, and all of those three things that actually enable those functional skills to develop. And in dyspraxia, there's a problem processing information, and this can occur at either one or all three of those stages. So if we think about actually kicking a ball to another person, you need to be able to understand the aim of the task. You need to be able to decide on which movements are going to be required. You need to be able to form a mental image of what that looks like and what's going to look like when it goes to the other person. You have to be able to look at the ball and see it where it actually is in space. You need to be able to move it into the right position. You need to be able to raise your leg. You need to be able to aim. So again, looking at where you're going to be kicking it to, and you need to be able to coordinate that kick so that the ball goes in the direction you want it to. So something that might come quite naturally to a lot of people, there's actually quite a lot of behind the scenes planning and processing going on to enable us to do that. And this is where dyspraxic individuals or DCD may find that either one, two, or all three of those different sort of processing issues may start to impact on their ability to be able to do that effectively. And so when we think of fine motor skills, we think of all those small movements. Now, handwriting is again a very obvious one, where you have to be able to hold your pencil correctly. You have to be able to coordinate very small, fine movements to be able to correctly write the different shapes of the letters and to sort of link them together to become words, and then appropriate spacing to become sentences and things like that. You can see here, this is an example of handwriting from an 11-year-old child with DCD, and you can see here some of the issues that he is experiencing with his handwriting. So the handwriting difficulties may be contributing factors to that, maybe a poor pencil grip, but not having very strong fingers, maybe some hypermobility in those fingers, perhaps difficulty actually sitting up straight. A lot of handwriting difficulties are actually caused by weak core strength and more of a gross motor sort of difficulties, in that they're not able to anchor themselves correctly at the table to then be able to use those fine motor movements. Again, there might be difficulties in positioning their paper correctly. They may not have a comfortable seating position. They may have the inaccurate hand-eye coordination. Again, what they're seeing and where their hand is not quite lined up correctly. And we can see examples like in the example we've just looked at, there's incorrect letter formation. Again, coordinating the movements correctly, maybe incomplete letter formation, not completely closing off certain letters. There might be lack of consistency in the direction of ascenders and descenders, inconsistent spacing between the words with either no spaces at all, too narrow spaces, too wide spaces, and there may be sort of either very heavy pressure on the pencil or very light pressure, depending on how that child is trying to compensate for their fine motor difficulties. Now, a lot of these difficulties we see very early on in education with very young children sort of being expected to be able to pick up a pencil and start writing, when actually their hand movements, their hand strength isn't there, their hand coordination and the fine motor strength isn't there. And so sometimes they do actually pick up quite sort of what we'd call bad habits, I suppose, just from having to sort of try and do something quite early on they weren't ready to do without having all that sort of input and therapy first. they've kind of compensated. So you quite often see a very awkward pen grip that's just then trying to make the shape of the letter as best they can with the skills and abilities that they've got. And so quite often with occupational therapy or specialist support, you're having to try and undo some of those techniques that they've developed and actually give them the strength and the motor strength and build that up first, and we're almost having to relearn some of those early skills. The Dyspraxia Foundation also highlights that as well as the obvious physical difficulties, there may be a range of co-occurring difficulties which can also have a serious negative impact on an individual's daily life. These might include some social and emotional difficulties, as well as problems with time management, planning, personal organisation, and they also may affect an adult's education or employment experiences. Quite often, individuals with DCD find it difficult to plan what they actually want to say in a social situation, and therefore that can then cause difficulties in those social situations, in those employment situations. And also, people with DCD also experience difficulties with memory, perception, and processing. So there may be some of those working memory difficulties, and there may be some of those slow processing of information as well. So that can all have a huge, that more sort of like that wider look of what dyspraxia actually is, can also really start to, you can see how it might start to impact on some of these wider life and not just the physical joining in the sport. Okay, so here's a nice image that I got from aboutdyspraxia.com, which I thought just showed some of those broader issues quite nicely. We've got the obvious sort of gross motor difficulties. That might be things like walking up and down stairs, being able to balance, issues getting dressed, putting things on the wrong order, putting your jumper on backwards. We've got some of these coordination issues, again with the more sort of physical activities, those bigger gross motor movements, difficulties with hopping, playing sports, running, organising your body sort of in those bigger ways, you're moving your body in space, bumping into things, being clumsy, all of those sorts of issues. You've also got here then again, we think of the motor coordination difficulties mentioned in the criteria. We've got the fine motor issues, which would include handwriting issues, could also include some manipulation difficulties. So, for example, difficulties doing buttons, handling classroom equipment, shoelaces, could even be like opening packets, opening food parcels, things like that could be affected by dyspraxia and those fine motor difficulties that we see. We then want to think about some of the more subtle things. So we'll go and have a look at the organisational difficulties. So, for example, an individual with dyspraxia often finds planning difficult. They may need some visual reminders to help them to consolidate their learning on their sequencing of what to do next. For example, visual timetables are very helpful, even when it comes to self-care at home, what to do first, wash your face and then brush your teeth, or however whatever they need help with, often having some visual reminders does help them quite a lot. Again, those memory difficulties, there's a lot of crossovers here with dyslexia. They might have difficulty with remembering sequences and rules. Things like learning times tables are often tricky with issues with dyspraxia, and some of those similar crossovers with dyslexic type profile as well. And then we come to the classroom, sort of more classroom-based issues we may be seeing. If we're in the classroom with a child, they may be sort of having difficulty getting their ideas down on paper. They may have difficulty listening. They may be seeming like they're not listening, but actually are listening. They might be affected by background noise a little bit more than others might be, and there may be problems with note taking and copying from the board because of the sort of load on working memory and the load that takes on actually processing what they're actually reading on the board to what they're then having to write. So there could be issues there. With communication, again, speech can actually be quite immature, partially sometimes because of the actual coordination involved in getting their mouth and their tongue around the actual sounds and coordinating that quite quickly to be able to speak at a normal pace. And sometimes it's more to do with the social aspect, and it might be more to do with their ability to plan what they're going to say and then get the right feedback from the person they're speaking to, and then plan what they're going to say next. That sort of aspect of social communication can be quite challenging. They may also get their words muddled up when they're talking. They may get their words round in the wrong way, because again, it's all that sort of behind the scenes planning and organising that your brain is doing when you're carrying out these day-to-day tasks may be impacted by the dyspraxia or DCD. And so now we need to think about actually how prevalent is dyspraxia or DCD. So we've thought a little bit about what it actually looks like. How common is it? So it's estimated approximately 5 to 6% of school-aged children, and it is considered to be a common neurodevelopmental disability in school-aged children. The DSM-5 indicates again a prevalence of DCD in children aged 5 to 11 years is approximately 5 to 6%. So that seems to be quite consistent across at least of those two sources of information. It says males are affected more than females, and estimates ranging between a ratio of 2 to 1 and 7 to 1. So it's a little bit of a discrepancy between those two figures there. And we need to think carefully about this, and if we're thinking critically about this, why might males be more affected than females? Is this the case, or is it because it's typically characterised by delays and deficits in the acquisition of those motor skills? So, for example, catching, throwing, kicking a ball, etc. And is it that we notice that more in boys who are unable to do some of those tasks than girls? Girls often play in a different way, and so it could be possibly that it's more masked in girls. And so that's something we need to be very mindful of when you're reading up on these sorts of figures. Be mindful of the fact that what is it because of the way we expect males to behave in a way that that's different from females. So that's always an interesting topic of conversation, are these sort of prevalence rates and looking at gender as a sort of factor in those. And again, with all of these specific learning difficulties, people don't often nicely fit into one neat diagnosis, and therefore we need to look and think about the co-occurring difficulties. Here's some figures from various studies. ADHD and DCD had a 60% co-occurrence. Specific language impairment and DCD, again 60%. DCD and reading difficulties, 55%. Social and emotional behavioural difficulties and DCD, 82%. And these are all cited in Sugden et al. 2008. So again, this is a very good article to just look into initially, just to get sort of that starting point for more information, particularly if you're going to write about DCD if you're going to do a presentation on this particular subject. That would be a really good starting point for you to explore this co-occurrence and these different crossovers in a little bit more detail. So the difficult question of what causes DCD, again, with all these specific learning difficulties, the causes are not fully known. It is suggested that there might be some differences in the brain structure and also the function. For example, Leonard et al. Support the fact that there's relatively little known about the neural aspect of the actual sort of difficulties people with DCD face, but they do think that underactivation of the right dorsolateral prefrontal cortex during the practice of a motor task could link in with why people with DCD find it difficult to acquire those new motor skills. And it's also suggested that there is some sort of impairment in cerebellar function, which fits in with the automaticity deficit hypothesis, which is suggesting that people find it difficult for motor movements to become automatic. So, for example, all of these motor skills have to be consciously monitored, so nothing happens effortlessly. Even something like walking, it's something they can't do. You quite often find people with DCD actually they can't walk and talk at the same time because they're having to actually really focus on the walking. They can't. An example as well, a child might be learning a song and a dance for a school play, and they know all the words to the song, but when they actually have to put some dance movements to it, they may not be able to actually do say the words and sing along to the song because they're focusing so hard on those motor coordination movements involved in the dancing. And I've got seen that in firsthand as well, that sort of difficulty. they have to be constantly monitoring these motor movements because they don't become automatic. There is a general consensus that DCD is a neurological disorder which may result from some sort of immaturity in the developing brain then. For example, Zhu et al. In 2012, they did a very large sort of reflective study on premature babies and their risk of DCD, and they found that the earlier a baby was born prematurely, the higher their risk of DCD was, but that risk then became normal once a child had reached full term. So there is a definite link there with DCD and premature babies. And if we think about the way that we're able to support premature babies from when they are born now, and how many premature babies are surviving very, very early births, we need to think maybe about how that might impact on prevalence rates in the future, and what we should be maybe looking out for in children who are seemingly unaffected by their premature birth, but possibly have some more of these subtle specific learning difficulties coming through as they grow up and move into education. ADDIE also highlights some extra risk factors which may not be linked to prematurity at all. So, for example, just a lack of oxygen around the time of birth can sometimes be a risk factor for DCD and possibly any early viral infections. And again, there is the possibility of genetic links. As with dyslexia, there does seem to be some sort of familial link as well, but nothing that's really been pinpointed as such conclusively. So there's again a range of factors which may impact on the chances of a child having DCD. So now I need to think about how DCD would actually be formally identified and diagnosed. The NHS provide a guidance for parents who are exploring a diagnosis of DCD for their child. They state that for a diagnosis of DCD to be made, your child would need to meet all of the following criteria. And again, these are pretty similar to the DSMV, just in more layman's terms and more parent-friendly terms. So the motor skills would be significantly below the level expected for their age and opportunities they've had to learn and use these skills. There is an issue here sometimes with some children may actually have had more input in practicing and developing certain skills than others, and so we need to be mindful that a cut-off point using sort of a standardized test can sometimes mean that some children might actually slip through the net. They may have had a lot of help with developing particular skills already, and so then they're not actually meeting the diagnostic criteria because of that. But generally the motor skills would still be significantly below the level expected for their age. And also these difficulties are sort of quite far reaching, and they're persistently affecting their day-to-day activities and achievements at school. Their symptoms would have first developed during an early stage of their development, and their lack of motor skills can't be better explained by long-term delay in other areas, for example, a general learning disability, a rare medical condition, something like cerebral palsy or muscular dystrophy. DCD should only be diagnosed in children with a general learning disability if their physical coordination is significantly more impaired than their mental abilities. The point of DCD is it's a specific difficulty that we don't sort of think, oh, they're finding these things difficult, but if they're finding lots of different things difficult as well, then we wouldn't be saying that's a specific difficulty. It's just part of their general learning disability. But if the motor coordination side of things is significantly lower than the rest of their functioning, then we could potentially diagnose DCD in that individual. Although DCD might be suspected in the preschool years, it's usually not possible to make a definite diagnosis before a child is age 4 or 5, and that's again because of all the different individual differences in motor development and coordination as a child is growing, but often a lot of physical milestones have been reached and met around 4 or 5. So that's when we can start to expect things to fall into place for most children developmentally when we're looking at the motor coordination side of things. Again, DCD is very much a medical diagnosis. It may be sort of investigated by a team of people, including occupational therapist and paediatrician. It would usually be, for example, I know in the Cardiff and the Vale, it would be the paediatrician that makes the actual formal diagnosis, looking at all of the other backgrounds and looking at excluding other causes, and the occupational therapist who would give their input and analysis of the actual motor coordination and skills as well. So there's no set agreed upon measures. It will be each different sort of NHS trust would have their own approach to this, but usually a range of methods used would be to use the movement assessment battery for children too, which measures the coordination, the motor performance, the manual dexterity. They look at things like aiming, catching, balance. They look at muscle power tests, grip strength, in-hand manipulation tasks, for example, puzzles and pegboards, handwriting, fluency and speed, and they'd also make some different observations and run through some checklists as well. So there's a range of different things they'll be looking at to sort of pull together all of the evidence needed to come to the conclusion that this child has got DCD. So there's another reason why it's very important that this individual with coordination difficulties is looked at by a medical team. And again, this because there's some red flags which would be possibly indicating other more serious and sinister sort of causes of these coordination difficulties. So, for example, if they'd recently had a head injury or trauma, if their motor skills had actually deteriorated, if they had a history of headaches, eye pain or blurred vision, if there were some gait abnormalities, if there was increased muscle tone or really very significantly poor muscle tone, if there was muscle tone or strength differences on one side of the body to the other, if there was difficulties with swallowing or feeding, if there's difficulty standing up, they can all be signs of something a lot more sort of serious that needs to be medically looked at in more detail. And there's also some amber flags as well that just require some further consideration. So, for example, if there was some actual musculoskeletal abnormalities, nucleocutaneous lesions, which can be linked with disorders of the nervous system, or if the child is avoiding eye contact or unwilling to engage socially, perhaps there's actually links with autistic spectrum disorder going on there. Dysmorphic features, and also any untreated visual impairments that might be an issue as well. So it's really important that the practitioners are getting that sort of really sort of holistic look medically at that child, so kind of almost rule out any other causes for these difficulties. There may be initial observations that could be made by an educational practitioner, for example. Many of the motor and behavioural difficulties, for example, lack of motivation, frustration or anger, or just giving up easily or avoiding certain tasks, they could be observed in the class and on the school playground. So there's things that you could be looking out for if you are within an educational setting, that could be sort of indicators that there's something going on with that particular child. And so obviously we need to think about how is DCD first picked up. It's not something you immediately would get referred to. You need that referral has to be made to the paediatric team or the OT. So there's no actual clear screening procedures for DCD. So it's not often diagnosed until after the age of 5, which is when they start going to school and when the difficulties of coordination, particularly handwriting, for example, may become more apparent. Kirby et al. Did a sort of comprehensive study that looked at the factors that increased the likelihood of referral for diagnosis, and they included things like if there was late developmental milestones, for example, not hitting the milestones for walking, taking longer than sort of 16 to 18 months to be able to walk, being later to talk. Sometimes skipping the crawling stage is something that they would look out for as well. So again, the health visitor is somebody who would come to visit, usually at home, the child, the baby when it's born, and also, up until the age of 5, they might be doing sort of regular checks and noting things like developmental milestones and if that child is reaching those on time. There's often parental concerns. For example, if a child has got a sibling who is achieved their milestones on time, but this child does not seem to be doing that, there's obviously that opposite comparison that parents often make. Similarly, if it's the first child, they may not really realise that this is an issue, and then suddenly they have a younger sibling coming along and doing everything so much quicker, and the penny drops a little bit more for the parents. Sometimes if there's a known diagnosis in other family members, they'll be a little bit more aware of what to look out for. and what it might look like. Again, and the presence of co-occurring developmental disorders. So for example, if the child has already had a good diagnosis or is getting a diagnosis for autistic spectrum disorder or ADHD, speech and language impairments or dyslexia, there may be more of an understanding and a knowledge of these issues from the parents' point of view that will prompt them to look for referral, or they may be advised to look for that referral. Could be the school are advising that. Knowledge and awareness of DCD by general practitioners. Again, if their GP is sort of knowledgeable about these areas, that is obviously going to improve the likelihood of getting a diagnosis in child and adolescent mental health services, paediatricians and teachers. The more of these professionals working with children are aware of this potential difficulty, the better likely they are to get the appropriate diagnosis. Also behaviours noticed by others that might cause concern, for example, low self-esteem, anxiety, depression, bullying, or any externalising behaviours, that sort of negative projection outwards of any internal frustrations. And that's the sort of thing, again, which could end up masking some of these difficulties, but perhaps hopefully would prompt people to look and try and dig a little bit deeper and work out why this child might be presenting with these sort of more emotional behaviours. And again, presence of other medical conditions is another sort of factor. If they're already in that system, they're already around a lot of medical practitioners, they're more likely to get that sort of diagnosis and get those issues picked up. So there are a number of checklists that are available to practitioners, to teachers, and they would often be used as sort of starting point just to kind of go through and help to organise the thoughts as to, is this child sort of raising enough concerns to warrant a further referral. This checklist is straight from the Dyspraxia Foundation's website, and the link is at the bottom of the slide. So, for example, thinking about a preschool child with dyspraxia, how would you recognise a preschool child with dyspraxia? They may be late in reaching the milestones, including rolling over, sitting, standing, walking and speaking, may not be able to run, hop, jump or catch or kick a ball, difficulty keeping friends or judging how to behave in company. So again, that's that sort of slightly social element of the planning and thinking about what to say or do before you do it. Has little understanding of concepts such as in, on or in front of, those sort of prepositions of where things are. Has difficulty in walking up and down stairs, poor at dressing, slow and hesitant in most actions, appears to not be able to learn anything instinctively, must be taught. Again, there's that difficulty with automatization, falling over frequently, poor pencil grip, can't do jigsaws or shape sorting games. Their artwork may be quite immature, and they may often be anxious and easily distracted. So that's looking at that preschool age. And then when a child is at school age, it would be the same difficulties as the preschool child likely, but with little or no improvement. So for example, some of those things are still causing them an issue. It's not something they're growing out of necessarily. They may be able to work on some of those skills, but they're still likely to be more significantly affected than their peers. They may also avoid PE and games. They might not do so well in class, but they might do better on a one-to-one basis. The attention span may be poor, and they may be easily distracted by certain visual stimuli or auditory stimuli. They may have trouble with maths and writing structured stories. They may have difficulty in copying from the blackboard. Their writing may be really laborious and maybe a little bit immature, and they may be unable to remember and or follow instructions and be generally poorly organised. Now, having just read through those checklists myself, and despite this being from the Dyspraxia Foundation, I can see this criticism of checklists and how actually they can be a little bit lengthy. They also a little bit poorly worded and not very sensitive. So this is a criticism made in 2007, and you think, just looking at the keywords that I've just pulled from the slides before, there's like quite a lot of mention of poor, poor this and poor that, slow, being slow, immature, doing badly at things. And so you can see the validity of that criticism, really, that sort of quite negative sounding, but obviously they're all the issues that parents would be concerned about. So it's hard to sort of really discuss those without sounding too negative. But again, a checklist can be helpful, but we mustn't place too much weight on every single aspect and every single box having to be ticked as well. It's just to give you a guide and a feel for, is this child likely to have DCD? Is it worth making that referral? This article in the Canadian Journal of Occupational Therapy explored the experiences of parents with children with developmental coordination disorder. The sample of parents were parents aged 35 to 49 years. Most of them were highly educated professional mothers. There were 10 boys and 3 girls aged 6 to 14 years. Now, thinking back to that criticality we talked about in seminar 1, we need to maybe think about some cautions re the sample. So, for example, the sample size, perhaps the sort of narrow cohort of parents that were interviewed and discussed their experiences. We might want to think about why those parents are having their children identified in the first place with these difficulties. Perhaps other parents who aren't in that group may not be as able to access that diagnosis in the first place. So there's lots of questions around that are quite interesting when we're thinking quite critically about these studies. But they looked at the lived experiences of parents, and they did identify key areas of the development of the parents' concerns about the child and how that actually came about to then eventually getting a referral for DCD. They talked about 3 different stages. Number 1 being unravelling the mystery, in those early stages of understanding those child's difficulties, having always felt possibly that something wasn't quite right about the way their child was developing, maybe some sort of nagging concerns that their child wasn't quite doing things in the same way as maybe their peers, but not necessarily having confidence to be sure about that. And then school experiences then as the child progressed into school. That then became more of a concern because obviously the problems with handwriting, written work, team sports, all of those difficulties become then more apparent. And then with secondary school, there could be the social and self-esteem problems that come hand in hand at times with DCD. And so that's all enhanced this difficulty. And then the stage 3 would be the negotiating the maze, trying to actually gain a diagnosis, trying to pinpoint what these difficulties are, trying to access the appropriate support. So really painting a picture of how that developed for parents, and quite a difficult sounding process as well for those parents, quite a concerning time for them. They also raised 3 main parenting dilemmas. So from the parents' point of view, what were their major sort of dilemmas and concerns about having this DCD diagnosis? Do they actually help the child with functional tasks to get it done? Do they try, how far do they push them to do things independently? Where's that fine balance between supporting the child and actually just being able to get on with everyday tasks? For example, doing shoelaces, if you're in a rush to get out the door, do you just do the shoelaces for the child? Do you just get them the Velcro shoes? Or do you actually just take that time to facilitate the independence, and when do you do that? Also looking at activity preferences, they generally would be looking to follow the child's lead, but then when do you challenge the child to change and try new things and push themselves? If they're naturally going to not want to do any sort of sporting activities, how are they then supposed to develop those skills? So it's that, again, that fine line, how far do we go with this? Do we follow the child? Do we follow our instincts to try and push them to develop and change? And then finally, the diagnosis aspect of it. Do we want that label for our child or do we not? And what all of the different issues surrounding labelling that we might discuss a little bit more in the lecture on assessment. So those sort of quite serious dilemmas that the parents are facing in this whole process. Another issue which is really important to not forget and to remember is that not everybody is able to access this DCD diagnosis in childhood, possibly due to sort of demand and cut-off points and things, or just not even having that process put in place for them. And we need to remember that DCD isn't something that children grow out of, and it is very much an issue throughout their lives. Although their difficulties and symptoms may evolve slightly as they move from childhood into adulthood, it's still very much an issue for them. And some adults may be seeking to get the right support for what they suspect is DCD, to support them in the workplace, to support them in their studies if they're at university, or just to generally help them with their day-to-day functioning. But the survey carried out by the Dyspraxia Foundation found that of almost 1,500 adults who were that took part in the study, they actually really highlighted how frustrating and distressing this process could be. Nearly a third of adults who went to their GP, for example, seeking assessment for dyspraxia, were told that the GP couldn't help, and 10% of survey respondents who felt that they had dyspraxia or DCD and they've actually been looking for a diagnosis for more than 2 years. So there's obviously not as many places to go to actually explore that diagnosis in adulthood, which is a huge issue and something that we need to be mindful of as well. So thinking about that transition from childhood and looking through the different developmental ages and stages all the way through to adulthood, we need to be thinking about what's the actual impact of DCD and how can it impact on children's lives and then teenagers' lives and then eventually adults' lives. So thinking about that, the initial sort of label that was used to describe DCD was talking about the sort of clumsy child syndrome, thinking about a child who maybe has accidents, falls over, or possibly avoids physical activity because of fearfulness, and could portray an image to be sort of lazy, not listening, not trying hard enough in school. So quite careless as well. So we need to be thinking about what kind of impact that DCD may have on that child, particularly if it's missed or overlooked or not understood. It's really important to realise that a child with DCD is not being careless, and he and she is likely to be following spatial information they've received. It's whether that's then processed and perceived effectively, and that will depend on the outcome. So a child will use clues that come from the environment through their senses. They will then need to organise them into the brain, relay them to the muscles, and then they will then produce efficient and effective movements. For a child with DCD, if they saw a table and perceived that table to be nearer than it actually was, if they're then to place a cup of juice or water on the table, it may end up crashing to the floor. And conversely, if that table appeared to be further away than it was, the child may bump into the table before they can even get there to put their juice on it. So there's lots of ways in which that processing and perceptual information can cause difficulties with DCD and that sort of clumsy seeming effect. Another example here, it may be the sequencing and the planning of the motor movements that could cause that sort of careless effect. And again, examples might be if they've got difficulties coordinating their fine motor movements, plus they may have weak core strength and hypermobility in her fingers, then obviously they're going to have much more messy or careless or rushed looking handwriting. Again, it's not necessarily the case. They may be putting a lot of effort in just to get that result. So it's very important to be mindful of those sorts of issues. But obviously there is a lot of hope when you're working with children with any kind of specific learning difficulty. It's important to understand that obviously the brain is very plastic. There's a lot of room for improvement in skills, even though DCD is a lifelong disorder. They're never going to not have it. But everyday actions and practicing movements, every time they do something, that's providing feedback, and so the child can gradually manage to make some adjustments until that action is correct. So routine, practicing a lot, overlearning, again trying to develop that automaticity that might be lacking can actually make a big difference. And conversely, new movements carried out in unfamiliar places are less likely to be efficient. Everything has to be quite safe and the same for those movements to be carried out effectively. And this puts forward a really strong case again for timely diagnosis and the right interventions and appropriate therapies to be put into place. Because when you're dealing with children, 9 times out of 10 early intervention is key. Now this is a poem written by a 9-year-old girl with DCD, and this just kind of gives us an insight really from a more personal point of view from this little girl who's written a poem about her day. So I will read it out to you. I get up in the morning, my head is in a spin. I don't want to get up, don't want the day to begin. I have my breakfast and get myself dressed. Sometimes my clothes go on wrong, but I try my best. My mum takes me to school, I go off to my class, I struggle through my work, I wish the time would pass. My writing is messy, my drawings are too, I'm no good at PE, I can't even do up my shoe. I wish my life wasn't this hard, I wish it was more fun. I wish nobody laughed at me, the race is over before I begun. I'd like to play more sports, but I'm never picked for teams. I wish I could be better, like I am in my dreams. And thinking back to that poem that we just heard, it's quite a sad poem. It's really quite a negative. That little girl's obviously having a lot of issues with her own self-esteem and where she belonged in amongst her peers. And it's really important to consider the strong link potentially between DCD and mental health difficulties. Harrowell et al. In 2017 found that individuals with DCD, and particularly females, had an increased risk of mental health difficulties in later adolescence. So we need to be thinking about any interventions that aim to promote resilience in DCD, which should involve improving social communication skills and self-esteem. All of those aspects, those more subtle aspects, are actually very, very important in trying to mitigate any effects on mental health. Another study by Lingham et al. In 2011 analysed the data from children with DCD. It actually had 346 children to analyse, and they used parent-reported questionnaire, the strengths and difficulties questionnaire, and they also looked at the child-reported short moods and feelings questionnaire to gain information from both parents and children. Again, they concluded that children with DCD had an increased risk of mental health difficulties actually as children, and often these would be more likely if they had low verbal IQ, poor self-esteem and had experiences of bullying. But conversely less likely if they had a high IQ and high self-esteem. So obviously trying to preserve self-esteem is quite an important aspect of working with children with DCD. Lingham et al. Went on to argue that children with DCD actually should be screened for mental health difficulties to try and address them again early on, and also possibly some interventions may focus on increasing self-esteem, tackling bullying, enhancing social interaction, and that those things may actually alleviate some of the risk of depression and behavioural difficulties in children with DCD. So they really explored that sort of more holistic kind of overview of DCD and of the sort of other areas in which it can impact on children. So what does successful intervention look like? Well, Sugden, Kirby and Dunford in 2008 again did a little sort of overview of the different types of interventions, and they found that these aspects of it would be important. The child and family centred support, consideration of family lifestyle, for example, child and adult priorities for intervention may differ. So something that considered a family centred support. Multidisciplinary approach, so for example looking at all of the different aspects or wider aspects of how DCD may affect a child's life, so it's not just education but it's also health and sports coaches as well. A task orientated and functional approach rather than a sort of theoretical approach. Looking at participation as a goal of intervention, modifying tasks and the environment to the needs of the child so they can join in with others and they can be joining in with whatever their peers are doing. Intervention that considered how transfer and generalisation issues are addressed. So obviously we're going to transfer those skills to other situations. And also interventions that considered developmental trajectory, so ways to help as they grow up. So looking not just at the here and now, but also looking at how their needs may change as they enter the teenage years and adulthood as well. Things like peer problems, altered self-perception, and again, the emotional health concerns. And there's been very much a shift towards involving the child's wishes during the intervention process, and very much that's something that's part of the new additional needs framework and the review sort of systems that are coming into effect. So it's really important again that children are able to evaluate their own competencies and establish goals for intervention. What do they actually want to be able to do? Their mum or dad might think they should be playing football more with their friends, but actually they may want to do something different. And I think it's very important that the child has a voice in that process. And again, that's something that has been linked with successful intervention, rather than trying to force children to fit into a box that we think is appropriate. Where do they want to be and what do they want to be achieving? So when we're actually working with children with DCD, it's about matching the match strategies as put forward by CanChild 2005. So that would be including modifying tasks to make them accessible, alter expectations of what will be achieved, teach them strategies in order to learn and develop that skill, and also change the environment perhaps if necessary, and help by understanding. Basically, the more insight and empathy you can have to somebody with DCD, the more you can find out about how they best learn and where their difficulties are and how they could be supported, the better. Now, obviously, you will be having a lecture later on, I think it's next week, about interventions for DCD and also dyscalculia. But I'll just mention quickly here just some basic ideas for developing fine motor skills and gross motor skills. There's various different programs that have been out for some time. They come in and out of favour. For example, Right Dance. Quite often things are put forward as being sort of this branded kind of intervention, and we have to really explore the evidence base for those and explore that against how effective they are. There's an evidence-based package in Cardiff and the Vale that the teachers use in schools, and teaching assistants will also help to deliver that. It's called the Handwriting Motorway, and that is sort of delivered on a sort of local authority wide scale to children, and it's sort of a programme to develop handwriting, but it also incorporates aspects of gross motor skills and general fine motor skills as well. Little things like having triangular pencil grips just to help develop the correct grips. There's lots of different pencil grips you can get. Using an angle board to make sure that the wrist is extended when writing. That can really help with developing those fine motor skills and enabling a child to actually sort of get the hand in the right position to be able to make the right movements for handwriting. And again, the Dyspraxia Foundation website will have lots of other information and practical ways to support, and Eleanor will be going through lots more of those with you as well, I'm sure. When we're thinking from an educational perspective, it's important that we understand whether teachers are even really aware of DCD and the potential impact on children. And Leonard et al. In 2015 raised the issue that actually they had limited knowledge of the disorder and those potential impacts on the child's academic skills, despite the fact that it is relatively high prevalence. So 5 to 6% would be at least one child per class in a normal primary school sort of setting. So this is obviously quite concerning, and which is why it's so important to be able to try and understand more about this difficulty if you are working within an educational setting. So to end on a more positive note, if you needed to find some positive examples of famous faces, as for dyslexia, there's some celebrities in the public eye who have talked about having dyspraxic type difficulties or DCD diagnosis. And I think that's quite a positive thing, although obviously we do have to be mindful that not all children will see DCD as feeling very particularly positive. But if there are some role models they can look up to, if people who, they've got the same sort of difficulties as me, sometimes that can be really helpful. And it sort of normalises a specific learning difficulty as well, because it's not such a sort of alien thing, because you may not know anybody else in your class or your school with that difficulty, but if there are other people that you've heard of that have experienced these problems, it can actually be quite helpful. So we've got David Bailey here, the photographer. He had likely DCD and dyslexia, although never formally identified, possibly just because he's an older gentleman and perhaps these difficulties weren't so formally identified when he was younger. Cara Delevingne, the model, actress and singer, she reports that she has DCD and ADHD. Daniel Radcliffe, the Harry Potter actor, says he can't tie his own shoelaces. He sort of describes his dyspraxic traits as well. And I don't know if you've noticed ever him being interviewed, and on TV or anything, it sometimes comes across a little bit socially awkward. So possibly some of those social sort of planning skills as well. Florence Welch, singer in Florence and the Machines, she talks quite openly about having dyspraxia and dyslexia. And so all very successful people who seem to have overcome any difficulties with those, and it certainly hasn't held them back. Well, they are all in the creative arts, which is interesting. It would be nice to have some more examples that have been successful in other fields. But these are the ones that we tend to hear about. These are the ones we tend to follow in the media. So hopefully then we've managed to cover the three main sort of objectives of this seminar, which was to explore what actually dyspraxia and DCD, what they actually are, what they might look like, what are some of the diagnostic criteria, and then also we've discussed briefly some of the etiology, what possibly might cause it, or what at least would enhance the risk of having DCD, and then also what good intervention might look like. We've touched on that, possibly not just the actual practical tasks, which you may look into a little bit more, but also thinking about whether we need to incorporate some of the social and emotional types of interventions as well as part of that. So if you have got any questions, by all means do get in touch, but I really do recommend, there's a lot of resources on the further reading section on Moodle for you, so please do just have a good read of everything before you come to me with questions, because I may just direct you to the reading materials. But yeah, of course, if you have any burning questions, please do get in touch. And just to give you a little focused, directed task to do, just to focus some of your reading and thinking around dyspraxia as well, I want you to think about how might DCD impact on aspects of day-to-day life, and you can choose either preschool 7 to 11 or 11 to 16 years, whichever you're most interested in, whichever your particular age group that you're focusing on is. And I want you to think about the three areas of self-care activities, what issues may crop up with self-care at that age group, recreational activities, so leisure, hobbies and things like that, and also then academic activities at that age. And again, we'll just have a little recap next time we see each other, next time I'm with you. We'll just use the beginning of that seminar to discuss any ideas that you've had around that. Okay, so here are all the references for this seminar. You can see there's absolutely tons of them. They go on to the next slide as well. Some of them I've actually put onto Moodle in the further reading section for you already, so please do have a look there, as I said before. And there's lots of different pathways to go off if you are interested in finding out that little bit more about this area. There should be plenty for you to have a look at. Thanks very much for your attention and time, and I will see you all soon. Thank you.